And basically, by changing the antigens, we can actually use this for a wide variety or many cancers. Uh-oh. Is the error okay? So we start. I started out in the breast clinic. So we initially did a autologous breast vaccine. And basically, the vaccine is quite simple. It has IL-2 and GM-CSF in it, with whatever the proper antigens are for the cancer. So we did 255 patients. And the main thing, and you see it's a variety of cancers, the main thing about this is that we found no dose-limiting adverse events or serious adverse events. The toxicity of this vaccine is very limited. We then did an in-house prostate vaccine after doing the breast cancer, and we used the antigens PSA, CEA, and CA125, which are commonly all expressed in prostate cancer. We wanted to use multiple antigens at that time, and we used the biological adjuvants IL-2 and GM-CSF, and these constant doses of the IL-2 and GM-CSF IL-2 is about 1,000-fold less than the therapeutic dose, so there's no side effects of that. And GM-CSF is about 20 to 30 times less than a therapeutic dose. And the point was, this is going to act locally because this is mixed together and given intradermally. So what patient group did we look at? Well, patients, this was in the actually mid-1990s. This is a long time ago, okay? So these were patients who did not want to get what the urologist wanted to get done, surgery or radiation. We had patients with rising PSAs between 4 and 10, biopsy-confirmed non-palpable prostate cancer, no metastatic disease, Gleason scores of 5 or 6, willing to receive only the vaccine as their primary therapy. We took the PSA before the vaccine. We vaccinated, what I said before, and then we vaccinated at weeks 1, 2, 3, 7, 11, and 15 in the same femoral triangle. And I said again, this is intradermally. Then we took this serum PSA again. We gave them a booster series afterwards of another 6 injections, alternating IL-2 at 11 million units with the PSA vaccine. They measured the PSA again. Okay. Response was basically. Let's skip this slide. This is the first. We did 12 patients. This is the results of the 12 patients. And first column, PSA before vaccine, in blue is what was before, and green means that they actually decreased after the vaccine. You can see the majority of the patients decreased in their PSAs, and we had follow-ups from 18 to 92 months on these patients. And the first 4 patients were rebiopsied, and 3 of them had no cancer in their rebiopsies, and we could have missed it, but there was no cancer in their rebiopsies, and 1 had 3% in one biopsy. Okay. So for 6 vaccines, 8 out of 12 patients actually had a response, and after 12, we had 6 out of 9, but actually 3 other patients already have gone off trial. Then we decided to go back and do this the way you're supposed to do it, which is using an IND. I worked with a physician, and we actually did it through the kind of triangle between physician, druggist, and patient. So we went back and decided to get an IND. So in order to do that, we had to raise money. So we became the Navy Cancer Vaccine Program, and with DoD congressional funding. And it's in the program. The vaccines are going to be done at the Naval Health Research Center, and under the Veterans Administration Medical Center and at UCSD Medical School. Put it together, and we were the sponsors. Of course, we had done patients at presentation without any other therapy. Well, the FDA was not willing to accept that. So we had to go to the same group basically that ProscaVax had used, was patients with biochemical failure with rising PSAs after initial treatment. Due to the fact that to make the recombinant PSA costs us about $1 million, we're a small company. We decided to use one antigen in this. We use PSA, the most likely to be effective, and we use the same biological activants, same low doses. The FDA again asked us to do a phase 1A, 1B study, and we would do 20 patients, which would get only the 6 vaccines with just the PSA, and then we were going to do 28 patients with the booster series, as I said before. Okay, this is we did a lymphocyte blastogenesis assay where we took the white blood cells from the blood of the patients, and we added that in culture. We added the lymphocytes and PSA antigen, and we measured proliferation by DNA synthesis with tritiethymidine. And you can see anything in green basically means an increase in immunity. We didn't have huge increases, but some of the patients you can see actually had increases all along. So we figured about 15 out of 18 patients had some immune response to the vaccine. I don't know if I even want to show this slide after all this discussion on doubling time, pro and con, but I did my thesis on doubling time, so I guess I believe in doubling time. So we looked at the PSA doubling time before and after vaccine, and we were able to find that 14 of 20 patients actually had an increase in their doubling time after the vaccine. So it seemed to have some effect on the growth of the tumor. Again, it's 15 to 18 had immunotherapy. And the immunotherapy, you can see increase in immunity had no relationship to the progression. And if you look in the first column, patient number, P means biochemical progression, RP means radiological progression. There were poor progression in the patients, and none of them related to the immunity really, but they had some relationship to the actual doubling time improvement. Here's a waterfall plot, and you can see the dotted line across the middle is 50% increase in the doubling time. We use that as a cutoff. And you can see to the left of this graph, patients with doubling times increased above 50%, and only one patient actually progressed. And if you look at patients where their doubling time did not increase, it was on the right-hand side under that line, you can see 3 of those patients actually progressed. So the relationship to progression and what the change in doubling time. And patient 20, also the fourth from the right, actually has progressed now at 43 weeks. Okay, this is looking at the progression dating. You see there are 4 progressions at 19 weeks follow-up, and then it was one patient went on a clinical trial at 31 weeks, but there's no more progressions, and at 43 weeks we had 1 more progression and 2 lost to follow-up. 1 year, only 13 patients actually have been followed for 1 year at this point, and 9 of the 13 9 of 13 have not progressed. Actually, only had 4 progressions from the initial. I'm only the second person who's had this problem.
It's just slow. There you go.
My finger's not heavy enough. Is that the problem? Is it too heavy or not heavy enough? So anyway. So my conclusion is that 20 patients have received all 6 vaccines. Another 20 patients have received all 6 vaccines have had a serious adverse event. Another 20 patients have had any dose-limiting adverse events. 15 to 18 patients who received 6 vaccines have had increased immune responses. 14 and 20 patients that received vaccines have had increase in PSA doubling time. 5 of 17 patients have progressed at 43 weeks, and 4 of 13 patients have progressed in 1 year. I think I'll skip this one. We have a phase 2 trial coming up. It's going to be at Bethesda Dickens Medical Center. Dr. Rupal Bhatt's going to be the PI. The investigators are Dr. Batt, Dr. Einstein, and Dr. Bubley. So participating institutions are Harvard Medical School, the two Dana-Farber Cancer Institute, and Bethesda Deaconess Medical Center. We're going to do 120 patients. This is going to go back to presentation because in our previous phase one I was discussing, there were only grade 1 toxicities. There was no major toxicity, so we can go back. This has been FDA approved, and it's 120 patients. 80 will be vaccinated with prostate cancer vaccine, and 40 will be control patients, and there'll be patients in the active surveillance category where surgery radiation has not been done yet. Progression-free survival, which will be determined by actually biopsies. Get biopsy every year. We'll be looking for a decrease. We'll be looking for a decrease in the amount of tumor in the biopsy sample.
Active surveillance patients getting vaccine versus no vaccine.
They're all sort of in active surveillance if you think about it, but one's going to get a vaccine on it.
So this is to see if you can attenuate the low-grade disease of patients who are on active surveillance to prevent the need for primary therapy.
Right.
Got it.
Yes, the point is to get away from the toxicity of the primary therapy. That's how we all started. In the 90s, as everybody in this room knows, if you went to your urologist and you had prostate cancer, you got surgery or radiation. That's how this all started. We were trying to give to patients that between that.
Do you have any data from neoadjuvant patients or patients who got the vaccine before they had their prostates removed or even before biopsies to see if there's lymphocyte infiltration?
No,
that was done with GM-CSF. That was also done with Sipuleucel and also done with Ipilimumab. So with varying results, but it's sort of a model for some of these early patients with immunotherapies.
No, we don't have any data.
You'll get it from the study probably.
Huh?
From this study, you'll be able to get post-treatment tissue, presumably by people who are having repeat biopsies.
Right. Any other questions?
When you're looking at PBMCs, I'm not very familiar with the lymphocyte plastogenesis assay, but we are using a lot of ELISpot, interferon gamma assays, ELISAs, as well as flow cytometry to really examine the subset of T cells that may be responsible. So I was wondering, are you detecting antigen-specific T cells, for example, to PSA or in circulation, since you're postulating that these T cells are then responsible to the drop in the PSA?
Yeah, the lymphocyte blastocyst assay was developed at NCI many years ago. It was showing in breast cancer that if you had immune responses in this assay, that your prognosis was good. If you didn't, it was bad. So that's Huffman and McCoy and Oldham, and a long time ago, but these were guys who were there at that time. So what basically we're doing is we're taking the antigen, putting it in a culture, and see if there's proliferation, which means there's been immunity. It tests both B and T. It's kind of a general, humoral and both types of immunity, cellular and humoral. That's good, I think, because when we looked at flow, because that was the next you kind of asked that question, we did look at flow in the blood of the patients, the breast cancer before and after, and it was kind of a mixed bag. We had an increase in natural killer cells, we had an increase in T cells, we had an increase in B cells. It was just so I didn't, So I think one of the problems with trying to do these specific tests afterwards is that you have all this mixed bags of things happening, and it's hard to really take one thing and think that's going to be predictive.
Right. I think you have to use a combination of tests, right, to really demonstrate what is a functional immune response that then correlates with clinical benefit.
Yeah, and we're going to do a lot of other testing with this Harvard trial, but we're still trying to figure that all out because storing the samples and deciding how to do all this is still complicated.
All right. Well, thank you very much. We're going to